We didn't sign on to be an accountable care organization because we thought we were going to make any money out of it. The transformations that organizations like ours have to go through to be able to achieve any kind of savings, I believe are going to cost more than any savings that are going to come from the program. We signed on because the kind of transformation that accountable care really calls for is the kind of transformation that's going to improve healthcare for people in this country.
An ACO is an accountable care organization, and the premise of ACO is to provide quality care to patients through management of data. So once patients share data with us, we can not only start to coordinate care for them and control the quality of care that they're receiving both within the Institute but also outside of the Institute. And through that we can eliminate duplication of services, we can ensure that the providers that they're seeking referrals to outside our doors are providing the same level of quality as we are, and then through that the overall healthcare cost will start to decline. So you should see premiums start to go down, and with that also a higher level of quality overall for patients in the communities and populations. Accountable care organizations are the next step after you become a patient-centered medical home. But for us in our organization, we believe that sort of being in the lead, being on the cutting edge of healthcare is where we belong. We enjoy innovating, we enjoy experimenting with models of care that are going to improve things. So we're never afraid of sort of leaping ahead with whatever the latest and greatest is to see whether or not it really works on improving care.
I think given the national climate as it relates to healthcare and the movement towards accountable care, it was really a natural segue for the Institute to progress into becoming an accountable care organization. Having implemented the electronic health record back in 2002, and then becoming a primary care medical home level 3 through NCQA in 2009, it was really just the next logical piece for us to move into. They've been making great strides. It's really more about educating and understanding that it's not an additional task that we're asking them to do. It's something that they've always done, just kind of bringing it more to the forefront, making them understand when to capture these patients and when the opportunity arises to really make sure that the patient understands the importance of the measure and why we're doing it and why it's important for their outcomes. Getting the data, you're really able to see a picture of what's happening with your patient population. And prior to receiving that data, you didn't know that those patients were routinely going to the emergency room for care, or that they were in the hospital out of state, or what the costs were associated with the care of those patients. And as a primary care provider, you may not have even known that that patient of yours has been receiving services outside your walls, and those costs were still being associated to your total population. So working with the health plans to really go through and identify those areas and getting that claims data was very helpful in moving the relationships along and seeing the success when you start to see the reduction in emergency room use or redundancy of tests just by sharing the data. So the EHR is wonderful in that it allows us to build decision support. So it allows us to build support mechanisms for our providers to help them identify patients. It helps us to alert our medical staff as well as our providers about clinically important measures that we want them to meet. It's a smart tool, so we can not only put data in to manage our patients, but we can also pull that data back out to make impact and develop interventions to provide better outcomes for our patients and help our providers in making the best decision supports they need to. Patient engagement is a huge piece of being successful in establishing that patient relationship. Engaging the primary care provider and the team around that patient's care plays a significant role in how that patient's going to continue to relate to the health center. And what we've done as an organization is we've identified patients that do choose the emergency room frequently, and we make sure that we continually outreach to those members, and that when they do call up, we get them in right away. We don't make them wait a day or two to be seen, that we have enough access to be able to have those members be seen as soon as possible.
What we currently see trending is patients utilizing emergency rooms more than primary care. And when we see this happening, you start to see rises in overall healthcare costs. So what we want to do is we want to provide education to our patients, ensuring them that coming to the primary care doctor and letting the primary care providers drive care will not only ensure that they're seeking the best quality care, but they're also getting services that are appropriate for the services they need.
There are certain services that our diabetic educators actually do for disease management training, for diabetic program and prevention that are not covered by health plans, traditionally on a fee-for-service basis. So those are proven, research has proven that those improve outcomes for the diabetic population. So we've been fortunate enough to develop some contracts that can help support an infrastructure and have those diabetic educators actually continue to perform services such as those to improve the outcomes. As far as where things are going, I think that where we will see things going is where the payment model is going to change significantly, and we're all going to be forced to form these relationships and collaborate with larger institutions to share in the total cost of care. That traditional fee-for-service methodology is going to go away. We are going to be forced to all work together to make sure that we share data, we reduce the unnecessary tests that occur, and that we continually communicate with all providers. So you have to communicate with the specialist, you have to communicate with the inpatient facilities and the residential care facilities. That's going to be a big component that we'll continue to see move down the road.
And so we're doing it because it's the right thing to do. We're doing it because we think we can convince commercial insurers and Medicaid managed care plans and others to engage in a shared savings model with us. And we're hoping that through identifying multiple organizations that we can do shared savings with, that eventually the savings that we can bring to the system will pay for the kind of transformational activities that we're going through.